Hello, my name is Jesse Almeida, and I'm a master's student studying robotics engineering at Worcester Polytechnic Institute. This presentation is based on the research that I helped conduct this past year with the Cognitive Medical Technology Lab. Our research is focused on an emerging surgical procedure that's performed in an office while the patient's awake. The image in the bottom right shows how this is performed. A physician passes the endoscope through the patient's nose where it travels down into their larynx. The endoscope is equipped with a camera at the tip and has an open channel that a laser fiber can go through. The laser fiber is then used to essentially burn off any tumors in the larynx. As you can see in the video, the physician has to manually target the tumors with the laser fiber too. Overall, the procedure is very beneficial for patients, lowering both surgical cost and recovery time compared to normal surgical resection that takes place in the operating room. However, there are some limitations with the procedure. The physician must manipulate the endoscope manually, which can limit the range of motion. For example, rotation is limited by how far the physician can twist their wrists. The laser fiber and camera also come out at opposite ends of the endoscope's face. Patients who might have lesions in locations that when the physician tries to aim there, the camera vision actually becomes obscured, and the physician can no longer see the area that they want to operate on. Issues such as these result in the patient having to be instead referred to the surgery in the operating room that I mentioned previously. So for our project, we hypothesized that the use of side-firing laser fibers could be utilized to treat a larger range inside the larynx. These side-firing fibers are ones that emit light at different angles, such as ones in the figure on the right. Our aim was to compare the performance of the forward-looking fiber that's currently used in the procedure to several angled fibers, specifically ones that emit light at 45, 70, and 90-degree angles. We compared the fibers by using a simulation to calculate how much surface area each of the laser fibers could operate on. Also, we looked at which fibers could operate on certain subregions of the larynx. For example, a region underneath the vocal fold has been historically difficult for physicians to treat. For the simulation, we deployed a virtual endoscope with a laser fiber and a 3D model of the larynx. We were able to obtain two high-resolution models from Dr. Bailey's group at the French National Research Center for Scientific Research, where they use microtomography X-ray scans of cadavers to generate high-resolution models. We then explored the possible space that the endoscope and laser fiber combination can move in and create a map of points that the laser tip itself can reach. And with these points, we were then able to calculate the total surface area of the larynx that the laser could treat. Here's an example of a completed simulation. The endoscope is traveling to a bunch of different generated points, and it slowly starts to paint the faces of the larynx model that the laser can see and operate on. Now on the right, these are plots of the configuration space as they're being generated, with the endoscope at the top and the laser fiber on the bottom. So let me explain a bit how this simulation works. So for the first step of exploration, we generated 10,000 possible endoscope configurations and then calculated the tip of the laser fiber at each of these. The endoscope has 3 degrees of freedom: translation, rotation, and bending at the tip. The laser fiber has just 2, translation and rotation. Together, each of these configurations is a 5-dimensional vector. And for each of these degrees of freedom, we consulted with a physician on the procedure and their bounds. So for example, the rotation of the endoscope, as I mentioned before, it can be limited in the procedure. So the physician told us that that limit is about plus or minus 100 degrees. So we use this information in a sampling-based motion planning algorithm called randomly exploring random trees to go through and generate valid configurations, and then calculated the tip position at each of these configurations. And in the figure, all these tip positions are reachable points that the laser and endoscope can reach, and those are in the red dots. Now, the second step iterated through each of these reachable points and then simulated the light that the laser would emit at that point. And this is done by casting rays in a cone shape from that tip position. And these rays are limited by the emission angle of the laser along with its maximum range. And these are both physical properties that are calculated using the actual laser that's used in the procedure. So we then use a Euler-Trumbauer ray triangle intersection algorithm on each of these rays to find the first surface that the laser would hit. All these surfaces are then considered tissue area that the laser fiber could operate on, and this is shown in the yellow in this figure. So these are the model results for the simulations that we ran on both of the larynx models. And there is a clear increase in operable area as the angle of the laser fiber increases. The area around the vocal fold in particular benefits from this increase in coverage. And this is the table that shows the numerical results of the operable surface area for each of the results. Overall, for larynx 1, there's a 67% increase from the forward-looking fiber to the 90-degree fiber. And for larynx 2, that's a 77% increase. What's pretty interesting is the discovery we made was that when the graph of reachable points is viewed from above, there's actually a distinct gap directly above the right vocal fold. And this occurred in every simulation we ran. So we brought this to the physician, who said that the right vocal fold was actually more difficult to reach in practice. And further dive into the literature validated his assessment. So we then sought to figure out the cause of this gap. As it turns out, it's a direct result of the kinematic limitations of the instruments themselves. The model on the bottom is of you looking down the length of the endoscope with the laser sticking out, and the other one is a picture looking head on to the endoscope. And before, we mentioned that the laser is off-center from the face, which will become important in a second. So here, we're also concerned with 2 of the 3 degrees of freedom of the endoscope. It can rotate plus or minus 100 degrees that I mentioned before. It can also bend in this front to back direction. So together, all these properties, when we combine that in an animation, we can see that there's actually a large area that the laser fiber can't traverse. And the lines of this gap match up with a gap in reachability that we found. So for the forward-looking fiber, this gap in reachable points causes a gap in the operable area on the right vocal fold, which further backed up the complaints of the physicians that the right vocal fold is more difficult to operate on. What was interesting was that when we introduced the 90-degree fiber, that gap in reachable points, although it was still there, there's no corresponding gap in operable area along the right vocal fold, which is a very interesting discovery. So in conclusion, we present the results of our simulations regarding the use of angled laser fibers in office-based laryngeal surgery. Based on our findings, we believe that the introduction and use of angled laser fibers would allow physicians to operate on a greater surface area, which would increase the pool of possible patients that could be treated in office instead of having to undergo full surgery in the operating room. This recommendation is further backed up by our discovery of the gap in reachability, in which our findings connected an issue already established in medical practice with findings based on empirical engineering data. We would like to thank the National Institute for Deafness and Communication Disorders at the NIH for their grant that allowed us to conduct this research, alongside Dr. Lucy Bailey and her lab group for access to the 3D models of the larynx, which greatly aided our research. I would also like to acknowledge everyone involved with the research at Comet Lab, including Isabel Chan, Alex Louisa, Professor Liu, and Professor Ficara, as well as our partner at Brigham and Women's Hospital in Boston, Dr. Carroll. Thank you for watching this presentation. Please contact me if you have any more questions or would like any more information. Thank you very much.